Welcome to the Critical Care Obstetrics podcast. I'm Stephanie Martin, maternal fetal medicine specialist and medical director at Clinical Concepts, and I'm here with my partner Suzanne McMurtry Baird, our nursing director, and just a fantastic person. I've missed you, Suzanne. You've been out of town.
I was out of town. Yeah, I mean, we've been out of town a lot teaching, but I took a vacation.
Well, and I got used to seeing you so much because we've been traveling like crazy, teaching all over the country the last couple of months and having a blast doing it. But it's, whew.
I know. And then I don't see you or talk to you for 9 days. And it's like,
having withdrawals.
Yeah, me too. So back to work.
Back to work. Yeah. But we love the podcast. So this doesn't feel like work.
No, it doesn't. It just getting to talk to you and then see you at the same time, you know.
And the only hard part is logistics of trying to find a time, you know. And then when Julie's able to be, when it's all three of us and we're in 3 different time zones sometimes, it's, so.
I know.
But Julie can't be with us today.
Right.
But we're going to be talking about one of our favorite topics, amniotic fluid embolism.
Yes, because there's so much that's going on simultaneously that requires that interprofessional team to react immediately and anticipate complications that are going to occur from the amniotic fluid embolus. So,
yeah, I feel like we just talk about it all the frickin' time and that people have got to be sick of hearing us talk about it. But then we go meet people and lecture, and it is always a topic of conversation. It's always a question. People always want to know more about it. So I think, and it covers so many different emergencies. I feel like let's talk about it.
Yeah, and we're usually most lectures we're covering the key components of how you would respond and react to those signs and symptoms of amniotic fluid embolism. But they're like, we'd love a lecture on amniotic fluid embolism. In fact, this fall, we are going to be teaching at A1 Sacramento, I believe, a full day on amniotic fluid embolism. And we're going to break down those different components. It's just another way of teaching about, the content of, breathing, blood pressure, and bleeding.
Yep.
Which we call the 3 Bs of amniotic fluid embolism, and following a case study through that. So, but it continues, like you said, all this spring of traveling, and almost every day we would get a question about AFE. I think it's also everybody, what is your biggest fear in clinical practice?
Yep.
And it's AFE.
Yeah, we did one of those word cloud surveys one time when we were at a big conference, and we had a couple hundred people there, and we did. If you're not familiar, it's one of those things where people can do a QR code, and they go to the site and they basically text in the answer to a question, and we just asked, "What's your biggest fear?" And the top fears were all really the same thing. It was cardiac arrest, maternal death, amniotic fluid embolism in no particular order. That it was just dominant. That's what everyone is afraid of.
Right.
And people really equate AFE with cardiac arrest. I mean, we see it all the time. If there's a cardiac arrest, the first default is, oh my gosh, that's an amniotic fluid embolism.
Exactly. And the reason that there should be an implemented and a well understanding of the criteria to diagnose an amniotic fluid embolism, because with that comes that anticipation of hemorrhage before it even occurs. So
we're going to get all into that. And I just want to give a spoiler alert. We're going to be talking about AOK in this. And so if you're like, well, what are they thinking about AOK? Well, if you've never heard us talk about this, you're going to know exactly how we feel very strongly. I have a whole episode just on AOK, and I can update it, but the opinion's the same. If you have heard me talk, our opinions on it. But there's a recent publication that really drives home a couple recent publications that really drive home the points. So We will address that before we're done today, if you're
Right.
curious.
Right. And like you said, this has been a consistent message from those who do the research in amniotic fluid embolism, not an opinion,
Mm-hmm.
not this is based upon best evidence that we have in management of amniotic fluid embolism and not based upon a case report.
So what's an amniotic fluid embolism? First of all, the name is never going to change,
Right.
but it's a misnomer.
You
It's
know,
just not. It's
it's not like a hunk of fluid coming through.
it's it's not a fetal clot.
Nope.
It's I mean, when years ago when they tried to change the name to anaphylactoid syndrome of pregnancy, that was much more accurate description of what's actually happening, but it's just never going to take hold. AFE is here to stay. We need to just embrace it. But you need to know this is not an embolism. This is a reaction.
Right. A reaction to the amniotic fluid that has entered into the maternal circulation, not because she had a bolus of fluid, which again, we
Well,
all
presumably it's
Mhm.
that. Like we don't
Yeah.
even really know that
Yeah.
we don't even really know that it's amniotic fluid entering the
Right.
circulation. We
Or
know
fetal
that
debris.
it's
Yeah.
right,
Whatever.
but she's clearly reacting to something.
Right. It's a
We don't yet
reaction.
understand what.
Like anaphylaxis,
Just like anaphylaxis.
just like the clinical picture of anaphylaxis with
Yep.
some added on things.
And let's also be very, very clear. An autopsy cannot confirm the diagnosis of an amniotic fluid embolism. It can exclude other causes. It is very, very important
Yes.
if the cause of death in pregnancy is not clear.
Right.
In my opinion, it's very, very important. But it's not going to say, aha, this was an amniotic fluid embolism.
I know.
It will only say, we found no other explanation.
And the key there is on autopsy that they find fetal debris in the pulmonary vasculature.
Right, but
That
expand on that.
yes,
That's the key to what?
exactly. The key that almost every patient that you did an autopsy on, or even if they were not an autopsy, for instance, back in the day when we used pulmonary
Wait,
artery
before you go
catheters.
there, before
Okay.
I need to clarify your statement. To
Okay.
be clear,
Yeah.
fetal debris in the pulmonary circulation means she was pregnant.
Right. That's what I was
Okay,
going
it
to get
does
to.
not mean
Right.
that she had an amniotic fluid embolism, and somebody please educate our pathology colleagues because
Right.
they do not understand this concept.
Yeah. That's my point was.
I know that's what you were saying,
You
but I
were
don't think it's what you said.
right. So when we would test, we would get pulmonary debris and out of pulmonary artery catheters, and the patient was not symptomatic. She wasn't having an amniotic fluid embolism. It's very common. I mean, that's what happens. So it doesn't mean that a patient is having an AFE just because you find that, or had an AFE just because you found that on autopsy. That theory or that thought has been disproven many years ago.
Decades ago.
Yeah, exactly.
I mean, this is literally a holdover
Right.
from the days of when this condition was first described almost 100 years ago.
Right.
Okay. Where, and it basically described, this women dying suddenly and on autopsy having debris in the pulmonary circulation, fetal debris, like squamous cells, for example, and keratin flakes, that kind of thing. But we've evolved since then, people. And this is a 100% clinical diagnosis. This is not an autopsy diagnosis.
Right. Right. Now, and that's so important because there is a lot of mislabeling. And then when you look at
Yes.
the patient case study, they did not meet the criteria for an amniotic fluid embolism. An example of that, they were having postpartum hemorrhage.
Mm-hmm.
And they died from the postpartum hemorrhage in DIC,
Mm-hmm.
not from an AFE.
Right. Or a pulmonary embolism. So, I saw a case once where she was labeled as having an amniotic fluid embolism, yet the autopsy and the intra-arrest echo documented a clot in the heart that disappeared on its way to the lungs. And autopsy confirmed PE. Like, it just doesn't make any sense that we're saying, nope, it wasn't PE. It was actually a much more rare condition of amniotic fluid embolism, which, by the way, didn't even meet the clinical diagnostic criteria. So, what are the clinical criteria? So, basically, it's 4 things.
Yeah.
Okay. And we talk about the 3 Bs. You'll hear us say that over and over. And if you're not aware, before I get into that, if you want to get continuing education credit for learning about amniotic fluid embolism, go to the amniotic fluid embolism website. I believe it's afesupport.org. If I'm wrong, you just type in amniotic fluid embolism or AFE,
Continuing
foundation,
education. Yeah.
and you will find it. And we developed a free to you course where you can get CE credits to learn about amniotic fluid embolism. And when we created that several years ago, with the support of the foundation and Miranda Clausen, who is the head of the AFE Foundation and an AFE survivor, we coined the 3 Bs. And that's your diagnostic criteria, and that is your management approach. And the 3 Bs are breathing, blood pressure, and bleeding. Okay. Now let's translate that into medical fancy speak. The first criteria is sudden onset of cardiopulmonary arrest or hypotension plus respiratory compromise around the time of birth. Second is DIC, so bleeding. And the last is an exclusion criteria for absence of fever. And that's because sepsis is so commonly mistaken for amniotic fluid embolism.
Right.
Did I leave anything out?
No, and I think that you're right. Sepsis, common undiagnosed cause of maternal compromise, as well as complications from anesthesia. So the maternal cardiac arrest and or hypotension.
Mm-hmm.
We see hypotension a lot in our pregnant population, and especially around the time that a patient gets regional anesthesia, okay, of some type, either epidural or spinal. And if untreated, can cause maternal arrest, right? And oftentimes, then that is labeled, oh, she had an AFE, right? But then you look at it around the time, but she would have maternal compromise. So I think it's important that when you look at the 3 Bs, it does match the criteria to diagnose and suspect AFE, but you will not see bleeding immediately. So they also said within 30 minutes of delivery. So that's the final one. So a lot of times you'll see this was 12 hours
while
later.
pregnant or within.
Right,
30
while
minutes,
pregnant or within 30 minutes of delivery. So I think you'll see a maternal compromise 12 hours later,
and they call it an AFE,
and they call it an AFE, and it's not. So it's important to understand that, because then you can anticipate down the road, and that is the hemorrhage component.
And I think that's a really key point, because we see DIC a fair amount in obstetrics, and we see hemorrhage a fair amount in obstetrics. But with the DIC that we typically see, it's hemorrhage first, uses up all the clotting factors. We visibly know they're bleeding. We might underestimate it. We might mismanage it, but we know that bleeding is occurring, and then they develop DIC. That's very different than what we see with AFE. With AFE, the DIC happens first because you get this system-wide response that's occurring intravascularly, and it's essentially sucking up all the clotting factors in a hidden way because she's reacting to, like in an anaphylactic type way, think snake bite type of way. She's got this system-wide reaction that's activating the clotting cascade intravascularly. Then she starts bleeding. So the bleeding follows the DIC. And so if you suspect an AFE, you have to be prepared that bleeding is coming, even if you don't see bleeding.
Which is one of the reasons that we wanted to talk about the AOK protocol.
Yes.
Because again, we're still getting asked about it. It's still in algorithms.
Mm-hmm.
For whatever reason.
Yeah, it needs to go bye-bye.
It needs to go bye-bye. Yeah. and because it's not based upon evidence.
So let's start, for those who might not be familiar, what AOK is. Do you want to explain it, or you want me to?
Well, since I have a hard time saying the second drug, I mess it up every single time. Like, I don't know why, because it's a miracle drug. You
Does
say that part and we'll talk about
would you
it.
know the word I can't pronounce in
What?
obstetrics?
What?
Okay, I'm gonna mess it up, especially with braces. You ready?
Okay.
Puerperium.
Purpurium.
Puer pur
Purpurium. Who
puerper
says that word? Like, who says that word? It's only in like nursing
Not
text.
me.
It
Not
says
me.
it's only in nursing textbooks, I think. I had it in my DMP project
Uh-huh.
because my faculty mentor really wanted me to put that word in there, and I'm like, okay. First of all, I got to look up how to spell it. Purpurium.
Yeah, I can never spell it.
Yeah,
AOK is atropine,
I could say that part.
ondansetron, and ketorolac. And basically, brief history, what happened is, I don't know, 15 years ago, an anesthesiologist introduced the idea of giving these medications at an anesthesia meeting. It was never published as research. It took off like wildfire.
It might have even been a CRNA.
I think it was an anesthesiologist
Okay.
that did it, but the CRNA population has really been driving it
Oh
quite, in
yeah,
my opinion,
it
in our
has. They
opinion,
have.
yeah. So the rationale for it, I mean, biologically, so one of the things you do in research is you look at biologic plausibility. Is there biologic plausibility that a treatment might actually have a benefit? Like, I'm not going to be thinking, oh, I'm going to use atropine to treat colon cancer. There's no biologic plausibility there, okay? But when you break down these meds, there is some biological plausibility. There is some reason to think chemically or physiologically that it might have some potential benefit. The problem is it's not been studied.
Yeah.
And it got implemented, and because people are looking for a magic bullet, a cure that does not exist. So it just got widely implemented with literally no data to support it.
Yeah, and I think that because it was given in case specific times when the clinicians were thinking a patient had an AFE and the patient lived, then they were thinking, then that worked. That was the magic bullet. That's the reason why the patient lived. But when you look at the data on AFE now, 40% mortality is a lot, or 20 to 40%, depending upon which database you look at. It's a lot. That's still really, really high. But when we started really looking at the mortality of AFE, it was like 86%, I remember.
Yeah, I mean, when you look at the data now, if
Yeah,
you do modern medical care appropriately, then the survival rates, your patient's more likely than not going to
to
survive.
live.
I mean,
Right.
that's statistically high mortality compared to a lot of other things,
Not
but
really high, but
it's not a death sentence, and it doesn't have to be a death sentence,
no.
but you do have to react. And so we have been harping on this for years, and
Yes.
finally other individuals and organizations are starting to make statements about this and
Hmm.
publish them. They're doing the work out there of getting this published. We teach it, haven't published an opinion on it, but it's our opinion's well known from
Hmm.
those who listen to us. But so there's a lot of things that have to go well. We do not in obstetrics, we do not do a great job of managing maternal cardiac arrest because it's a relatively rare event. And if we're going to take time away, distract, add additional responsibilities and duties, then we're not going to be able to complete the necessary proven interventions.
Well, I would say we have a long way to go too in managing respiratory compromise as well as
Yes,
hemorrhage.
absolutely.
Also, because still hemorrhage is one of the highest causes of maternal death in the United States,
Yep.
even after all of our education and interventions and algorithms that we have put into place in our clinical practice, it is still one of the largest causes, or as far as percentage wise, of maternal death in the US.
Yes. I mean, when you just, when we look at teams and when you're simulating with your team members, it's very difficult to accomplish all the things that need to be done in a patient who's either in cardiac arrest or who is needing to be intubated, or at the same time, if she's got an AFE, she's going to be hypotensive or in shock, plus needing to be intubated or escalating oxygen support. That we know which direction this is going. It's not going to end well. You're going to have to do some interventions. And so, to think, oh, we'll just give these 3 medications because why not? That's that. First of all, you could be harming the patient.
Yes, that's the key, I think, with this new article that's out, and the research and looking at what these medications do or
So
the potentially for doing.
we'll put a link to the article, all the publications that we're talking about. We'll put the references in the show notes. But what we're talking about, what we're referencing, are 2 things. One is a publication that just came out in what we call the Green Journal of Obstetrics and Gynecology on the use of atropine, ondansetron, and ketorolac in suspected amniotic fluid embolism by a group of clinicians and researchers who have business writing about this. They know this topic. They're experts in this topic. And Steve Clark in particular is, he published one of the first articles that talked about the presence of fetal debris in the maternal circulation. So, well-established experts in this area.
Right. Steve Clark was the lead in the group that developed the first registry for
Yes.
AFE in the United States.
And basically, they came out on this, and the American Heart Association in the most recent guidelines for maternal cardiac arrest, which we'll put the link again, but it's called, special circumstances. So where they address like pediatric, but also pregnancy. And for the first time, we see AOK is not part of the resuscitation for amniotic fluid embolism. And I want to read the conclusion that they published in this Pacheco Clark article. Okay, you ready? Can I read it?
Yeah.
Okay. We caution against the widespread use of AOK protocol for suspected cases of AFE and remind clinicians of the many disappointing histories of medical interventions later discredited after extensive, robust, basic science, translational, and clinical research. Ensuring adequate oxygenation, supporting blood pressure, first B, treating heart failure, and aggressively managing coagulopathy, there's your other B's, remain the mainstays of therapy and should be recognized as the standard of care.
It sounds like one of our lectures on a.
Love it.
I know. When we read this, we were like,
Finally.
oh, man, this is what we've been talking about for years now, because we don't just routinely go around putting things in IVs during maternal compromise because you can. And that's
Right.
essentially what this is. It's theorized, right, that these meds
Pure
might
theory.
help, but it's never been shown to help.
So in this article, they have 7. So the sum total of the world literature on AOK for AFE is 7 case reports, not 7 case series, 7 patients.
7
Okay.
patients.
And they basically break it down. Now, if you want to hear more about this on our Patreon, we have a whole episode from a few months ago where we dissect this publication and talk about it a lot more.
Right.
But the bottom line is, and you can find that at patreon.com/CCOB, but basically, we don't have any data, not one single stitch of data that says that this does any benefit. These medications have potential for particular harm, especially if you think ketorolac. That's the brand name, one of the brand names, or I don't know if there's more, is Toradol. You guys are familiar with this. Do we give this to somebody who has risk of bleeding?
Mm-hmm.
I mean,
I
we
know,
use
that's
it with
crazy.
caution, right?
Right. Right. And
Renal disease, renal insufficiency. Is a patient in cardiac arrest going to have good renal perfusion?
right. Right. These medications are not without their own set of side effects. And especially in a patient that is going to bleed. That is one of the criteria. She's gonna develop DIC, and now we're giving a med that may prevent her from clotting.
Yeah. And atropine, major cardiac effects. Like, it's a cardiac
Major
drug.
cardiac effects. It's in that ACLS algorithm for bradycardia. And what happens if your patient is already, maybe she's not bradycardic and you're giving her this medication that has major cardiac effects?
Yeah, I think I'm just glad it finally got published in 2 different places where it just supports it. So, you guys listening, if you're at a facility and you're like, "Oh my god, that's in our algorithm." Well, you need to just put it on your agenda, the next agenda for changing your protocols and get it off because
Get it off.
not only is it not standard of care, it's potentially harmful and it's an unproven therapy.
And the head of your anesthesiology programs need to discuss this too, to say, this is not our priority if we have a patient who is suspected of having an AFE. We are needing to focus on the 3 Bs:
Yes.
breathing,
Mhm.
blood pressure,
Mhm.
and bleeding.
That's right.
And that, y'all, we have so much work to do in those 3 categories that we can focus on those. And I want to also point out that we said this a bit in the beginning, this team approach. Oftentimes we do not get our team involved in responding and practicing in these OB emergencies in our simulation. And it is not sufficient just for nurses to be practicing this. And
Yes.
we see that every time we're in a hospital and we're simulating with a team, that the nurses have done simulation in their pod, and physicians may or may not have done simulation in their pod. And then here's the anesthesiologists that have never practiced with the team uh, together, and you can tell.
100% you can tell.
I would be Can you imagine if a football team did that? I know Julie always brings up the sports analogies and everything, and she would bring this up now. You imagine an NFL team going out there to, this offense is practiced over here, and the defense is practiced over here, and the special teams have practiced over there, but they've never scrimmaged or they've never
Yeah.
played in a game
They've never
together.
played a game together. I mean, that's what we're essentially doing, right?
It is, and this has got to change. We have a major issue with severe maternal morbidity and maternal mortality. And we have to figure out solutions together on how we're going to respond to OB emergencies and how we're going to manage these patients. And that takes a team, not an individual, not a protocol or policy. Policy. But we've got to be a team in how we approach this.
And I would say, while people are so overwhelmed with the idea of an
Yeah.
amniotic fluid embolism, I totally get it. I
Yeah.
understand why. If you're practicing for dealing with respiratory compromise, if you're practicing dealing with maternal cardiac arrest from whatever cause, if you're practicing dealing with hemorrhage and DIC, then you're going to be ready to deal with an amniotic fluid embolism. The challenge is that all these things are happening at once, which is exactly the reason why you don't want to add more complexity by putting in unproven therapies.
Right. And we would recommend you take them one at a time.
Right.
Perfect your respiratory compromise, your first B, breathing. Perfect your maternal cardiac arrest, your blood pressure, and then perfect the hemorrhage.
Yeah.
And then you can practice them all together.
Right.
And the AFE Foundation has a simulation toolkit that Julie Arafe worked on with Mallory Seffold from, is she from Kansas or Missouri? I'm drawing a blank, but one of the two. But she is an Kansas, and she's an expert in simulation as well. Use that. It is an excellent resource, free to download, and take the course and use that simulation toolkit and separate them out. Do the first B, the second B,
Mhm.
then the third B,
Mhm.
and then you can pull it all together so you're not so overwhelmed. To just go in with your team for the first time that you've never practiced together and all of a sudden attack everything at one time, those 3 complications in one diagnosis can be very overwhelming.
It can be. And then, some of you are probably thinking, well, AFE is different. It is different. There are obviously going to be some differences. And one of the key things that's highlighted in many, reviews and conversations about this is the right heart failure. So I just want to
Mhm.
highlight that just for a minute.
Yes.
So what happens in amniotic fluid embolism is that you get pulmonary vasoconstriction. You essentially get acute onset of high blood pressure in the lungs. So it's very difficult for blood to get out of the right side of the heart into the lungs and pick up oxygen. Okay. Now the right heart is not designed to push against high pressures. It's designed to push against pressures under 20 millimeters of mercury. The systole. So it's just not designed for high pressure. So it is quickly and easily going to get overwhelmed and fail. So right heart failure is really a hallmark. It's not a diagnostic criteria, but it is a hallmark of what you see with amniotic fluid embolism. And there's strategies for dealing with that, but you need to recognize the possibility. There's another much more common cause of maternal cardiac arrest, which has the same issue. I'm going to give you a second to think of it. Pulmonary embolism. It's the same thing you see with pulmonary embolism, because when you have a physical obstruction, not vasoconstriction, but a physical blockage of blood leaving the right side of the heart, that's called cor pulmonale, okay? And it's basically right heart failure. You're not going to be able to tell the difference, just by looking at the heart unless you see a clot in the heart. So you see a clot in the heart, you're going to be thinking pulmonary embolism. It's in transit, right? But these are not unfamiliar concepts to your code teams, to your ICU teams. But what they may not understand is that right heart failure can be a component of amniotic fluid embolism. So it's one of those things when you're practicing that your checklists and your algorithms that you use during the arrest or during the event will guide the conversations that need to take place between the teams, because your intensivists don't know what they don't know.
Right.
And you don't know what you don't know.
Right. And again, I think you highlight too that when you think about that initial pathophysiology of the
Mhm.
sudden acute onset of severe pulmonary hypertension, everything's backing up on the right side.
Yeah.
The key in management of that patient at that time is to not bolus a bazillion liters of crystalloid
Right.
on that patient at that time, because you're going to make the situation worse.
Right. So the challenge is, if you don't consider amniotic fluid embolism, your patient could be either in shock or in cardiac arrest, and you may be tempted to give her volume, which is not necessarily going to help you in this situation. So it does get a little bit more complicated, but that's why there's a basic response to everybody when they initially present, and that's what you have to practice. Then it's how are they responding? Why is this happening to this patient at this time? You're going through your differential diagnosis as a team, talking through what the possibilities are, guiding additional workup, additional evaluation, et cetera.
Getting echo to the bedside
Yes.
to look at that right-sided strain with, the hypertension, pulmonary hypertension is so important. And then once you see that, early ECMO is now recommended soon, for these patients in the resuscitation, and then the anticipation of what's to come down the road,
Mhm.
because she's going to need large bore um, IV access, multiple, not just peripheral lines, but a central line. And then the volume resuscitation later on comes in with the hemorrhage and DIC. So again, it's that
Yep.
anticipation of where is the patient now, stabilizing that component, and where is she going? And when you understand the why, it really makes the management just click easier. It helps the team in discussion of how they manage. Because again, this is something that your ICU teams may or may not have ever seen and may or may not know how to manage. So you and
Well,
OB are also driving this.
right. Well, they're going to know how to manage right heart failure,
Right.
but they may not recognize what else is going on. And they're not going to be
Right.
thinking, they're going to see right heart failure. They're not going to be thinking DIC is next.
No, No, no. No, I know. That's why I said with
Yeah,
OB,
they don't know what
you're
they don't know.
anticipating you're going sudden acute onset,
Mhm.
with the 2 first Bs, and then you're like, "Here it's coming." And again, the ICU team, they may or may not have ever seen this type of hemorrhage. If they haven't dealt with a
Correct.
pregnant patient or, that has had massive hemorrhage, they may or may not. I mean, this is not an 80-year-old with COPD.
Right. This is yes. So this is why they're critically ill for all the obvious things we've been talking about. The management can get very nuanced. Your initial resuscitation is the same.
Right. Right.
Recognizing how AFE is different, okay, DIC before hemorrhage, right heart failure early on,
Initially, and then left heart failure.
and then left, yes. I mean, it's yeah, but you're still gonna be resuscitating in the same way. Those first 5 minutes, that's yours, OB team. We've
Mhm.
talked about that. Your ICU team, your code team is not gonna be there in the first 5 minutes. Assume they're not gonna be
Yeah.
there. They might, assume they're not. Be
Right.
ready.
Right. So it's a and that can't be a one-person trained
No,
project
no. This
again.
is a team. Yeah.
Yeah. So, pull this article and take a look at it. It it's also helpful, again, just from a nursing perspective, because oftentimes nurses bring this up as to their concern about, again, their worst nightmare, and especially in rural settings. We've done several rural lectures lately, about rural settings, and that is their biggest fear because of the resources that they need to resuscitate an AFE patient. It's tremendous. And who do they pull from the hospital to help them resuscitate that patient? And there may or may not even be an OB physician in house or a midwife.
And to that, I would say you can't be prepared for everything all the time. But if you are in a under-resourced facility and you're prepared for hemorrhage, you've got a plan for hemorrhage, you've got a plan for cardiac arrest,
Right.
then you've got a plan for AFE.
Right.
Not everything can be managed everywhere, every time,
Right.
but you do have to have a plan in place for the most common obstetric emergencies. And if you're prepared for the most common obstetric emergencies, you're at least more prepared for an amniotic fluid embolism. And then
Right.
you've got to know what your resources are beyond that. How quickly can you mobilize transport? Who can you get where, when, how?
Yeah. But the point being is everybody has different resources that we always talk
Yeah,
about. You've got to have
huge.
what this looks like in your hospital.
Yep. You got to be prepared for at least the most common, and preparing for the most common makes you more prepared for something like this.
And the most common are going to be breathing, blood pressure,
Bleeding and
and
blood pressure.
bleeding, right? The 3 Bs.
Yep.
Those are the
Yep.
most common.
Yep.
But what I'm saying from a nursing perspective is to have this evidence. You don't have to do a lit search on that you may or may not even have resources for.
Mm-hmm.
Pull this one article. It has all the cases that are in there. It also discusses why or why not this patient even had an AFE.
Most of them didn't
And
meet criteria for AFE in this
right.
review of these 7 cases.
Right, and it gives
Yeah.
a really brief,
Mhm.
description about AFE, but it also goes into why you may or may not wanna even give it
Mhm.
any of these
And
medications,
we
so
go into all of that on our
yeah,
Patreon if you wanna hear more, patreon.com/CCOB.
yeah, so
But
pull this and have your rationales.
so hopefully, well, that's our current opinions about AFE. I don't think they've changed.
Hasn't changed.
AOK is not AOK.
It's not A-OK. Yeah,
Never has been. Maybe some distant future it will be. It is not currently. It is an experimental therapy. You should not be experimenting on your patients, in my opinion. So
I
get that
and I
changed in your hospitals.
I agree, and if we knew of a magic potion, we'd be the first ones promoting it.
Oh my gosh. I just want to unbrainwash people first.
Yeah,
But yes.
we're trying. So pass the word, guys.
Mm,
We appreciate y'all listening. Um, if you want more information, like Stephanie said, join our Patreon community. We love our community and want to get the word out and continue our podcast information on that platform. Join us on YouTube. Subscribe to our channel and on all of our social media accounts. We're really loving hearing from y'all and send us some suggestions for our podcast as well as Patreons, and ask us questions on our social media. You can reach us there anytime or at our website, www.clinicalconceptsnob.com, and reach out to us if you need evaluation for your hospital, or maybe you've had an AFE and you'd love to bring us in to simulate with your team and to help you with your OB emergency responses. So we'd love to work with you on that as well.
And I think episode is going to come out right before we are at A1 in Orlando. So you guys can find us there.
Yeah.
We've got our post-con presentation on Wednesday. And we'll see you guys in Orlando, Florida. Track us down and find us if you're there.
Yeah, love to see y'all.